Hello, everyone. Thank you so much for joining us today. We'll get started in a few minutes as folks continue to join. So just give it a couple of seconds. Okay. Well, hello, everyone. Again, thank you so much for joining us. We'll get started. We're excited to have you with us for the second part of our educational webinar series. Today, we'll cover best practices from 6 departments of public health. And the teams are across Los Angeles, Sacramento, Tulare, Madera, San Luis Obispo, and San Francisco counties who will share their work at the intersection of public health and homelessness. Also, we welcome your thoughts, questions, and ideas about how today's went, and please use the chat to put any questions and comments. And me and my colleague, Alyssa, will be here to answer any questions as best as possible. And just to introduce myself, my name is Sadaka. I'm a policy analyst, and alongside me is Alyssa, directing analyst at Homebase. Homebase is a nonprofit technical assistance provider. We offer technical assistance to continuums of care across the nation, working with communities to prevent and end homelessness. And to give some background for today's webinar, this work is based on understanding that public health and healthcare and housing and homelessness are deeply interconnected. Last year, we began collaborating with the California Department of Public Health to help them connect local health jurisdictions to local homeless systems of care, adopting a cross-sector approach to improve outcomes for people experiencing homelessness. We surveyed local health jurisdictions and public health departments to better understand their involvement with homelessness in their communities. And additionally, we conducted interviews and 5 regional listening sessions. As a part of this project, we're hosting several trainings to increase basic understanding of the homeless system of care for public health departments. And today's, like I said earlier, you will hear about best practices from 6 departments of public health. And we are fortunate to have the following session topics and speakers. First, you will hear from Tulare County, from Michelle and Sarai. Then you will hear from Michelle Schwarzman from San Luis Obispo County. And next you will hear from Will Nicholas from Los Angeles County. And we'll have a pause for questions and answers for those 3 presentations in the beginning. And then next you will hear from Dara Papao from San Francisco. And then you will hear from Arlie Cruz from Madera County, and Kyle, Leanna, and Lisa from Sacramento County. And then we'll end it off with questions and further discussion. Alyssa, did you want to say anything before we get started?
Just to say that I'm really excited for today's discussion. And, we just have such a fabulous array of different kinds of best practices and ways of kind of bridging the gap between the homeless system of care and public health departments. And I think that's going to be really wonderful. As Sadaka mentioned, the work that we've been doing with the California Department of Public Health has really been focused on their desire to support this connection between local health jurisdictions and homeless systems of care. And we've done, surveys and interviews and focus groups, and so many of you have joined and participated in that. And through that work, we really heard not only the amazing best practices that are going on, but we also heard a desire to learn more, a real hunger to say, like, what else are people doing? How are people doing this work? And so this particular webinar is really trying to start the process of meeting some of that need and curiosity. So really just thrilled to hear from all of you. Thanks to our presenters. Thanks to all of you who have shared a lot of wisdom and perspectives with us already. So that's it. Thank you so much.
And then I'll pass it to Michelle and Sarai from Tulare County's Public Health.
Good morning, everybody. Happy Monday. I'd like to start today with talking about our Tulare County Public Health homeless efforts. My name is Michelle, and I'm a public health manager for Tulare County. And I also have Sarai with me.
Hi, good morning. My name is Sarai. I'm the Public Health Program Coordinator with Tulare County Public Health.
Okay, next slide. So here in Tulare County, we have our objectives of what we'd like to share with you today, our efforts, some data, and how we are addressing homelessness and the unhoused here in our area. Next slide. So how did it get started? How did Tulare County Public Health get involved with the homeless efforts in our county? In 2020, it was a Board of Supervisor presentation to the board to address homelessness in our county in 2020, kind of thrust that through, especially with COVID. Once COVID hit, as well as, sheltering those in place, getting people off the streets and working with HomeKey. In 2021, our agency, HHSA, formed the multidisciplinary team to coordinate the delivery of services to the homeless. And then as we moved to our current process, public health is now part of that multidisciplinary team. We have a health educator and a nurses to help with boots on the ground in our community, working with the unhoused. And so this was all an effort to address and overcome our homeless crisis. I'm sure all the counties are impacted. It's collaborative. It's a coordinated approach to address complex health needs, and a lot of education to raise awareness about important health issues and health behaviors. And so we want to get those that are unhoused connected with health resources. We also have our homeless task force through our agency that meets once a month to advise and assist us in addressing those efforts. And this is to help coordinate local services and programs and service delivery. One of the things that recently happened was that our multidisciplinary team has now been renamed to the Community Coordination Team and aligned itself with CalLane ECM services. So you have enhanced care management and the multidisciplinary team working together to provide services to the unhoused. Next slide. Public health also was part of the point in time count shared with King's Tulare Homeless Alliance, counting the number of unhoused we have in our county. This information is gathered every year to assess where we're at. And so what we found through the data is that a lot of Tulare County unhoused are white and or Hispanic. It's like a 50-50 between the ages of 35 and 54. Next slide. Here's some more data. As we can see, the cost of rent, the cost of housing has increased in our county. What we found from year to year is that there's been a 16% increase in those that are experiencing, homelessness, being unsheltered, and a 25% increase in the number of those experience chronic homelessness. Again, the data indicates that most are single, homeless for over a year, and experience substance use disorder and mental health concerns. They're challenged by that, which is like a 50-50, assessment. So that's our data for Tulare County and how public health got involved. And then I'll send it over to Sarai to complete the rest of our presentation.
Thank you, Michelle. Next slide, please. So now I'm gonna be talking about the community coordination team and the collaboration with public health, just to provide a little bit of overview about the community coordination team. We have members of CalWORS that are providing assistance to individuals about receiving medical, receiving CalFresh. We have behavioral health. This include the alcohol and other drugs programs for them to access those services if needed. We have public health, and we have members or staff from the Visalia Healthcare Center. So we are trying to promote accessing services that are needed by the unhoused population. So they provide a comprehensive range of services to support individuals in need. For example, some of the services provided, they offer vouchers for identification, birth certificates, social security, and access with applications for medical, CalFresh. They also are able to distribute incentives such as bus passes for them to access clothes. They offer substance use counseling. They provide probation assistance and adult protected services for individuals that are age 60 and above. As Michelle was mentioning, now with ECM, they help clients connect with medical appointments and treatments, including drug, mental, physical, and domestic abuse care. Additionally, a mental health crisis worker is available to assist those experiencing a 5150 situation or any kind of mental health crisis. As mentioned before, public health is part of the collaboration. We have health education staff that is able to provide health education and referral to our prevention and education program that include the STD, HIV program, and that one can be maybe referring individuals to access testing. We might have, or we might encounter individuals who, for example, have been diagnosed with an STI or even HIV, just referring those individuals to access treatment, provide some education about the use of like safe sex materials to prevent those type of diseases or STIs or HIV. We also have some the health education staff providing some education about the smoking cessation, vaping, where to access services in case they need it. They provide some information about nutrition. They also provide some education about car seat safety program, refer individuals to our MCH program, the maternal child adolescent health program. There are also able to and as mentioned, the goal is to refer those individuals to access medical care or access those services needed. So they're also able to be referred to any other public health resources. And that's working in collaboration with the licensed vocational nurse. The nurse is able to provide health assessments. So they're doing the depression screening, physical assessments, provide health education on disease-specific issues. For example, we might encounter someone who might be diabetic that may need some one-on-one about how to check their glucose, the importance of like taking their medication. Another important task of the nurse is make referrals to access medical services. And this is in collaboration with the Visalia Healthcare Center for them to access services and how it works. For example, the nurse or like the health education assistant, when they go out to do the outreach, they might be asking, do you need a medical appointment? Or for example, if they have like a patient, like the previous example that might be diabetic, that they might need a refill, or like they might need to do like a physical. So they're able to connect with the clinic for them to establish care or maybe make an appointment. Representatives from the clinic or staff from the clinic is able to go to that specific location, pick the clients for them to receive medical services. So it's that's what we're trying to do, just making sure they're receiving the services that they need. And all the referrals are made on HMIS. So this is the system that Tulare County is using currently to make those referrals for them to access medical care. Next slide, please. Right here, we have some pictures about the outreach locations. I included a map for those who might not be familiar with Tulare County. So we have 3 specific areas in Tulare County that we are doing some outreach. We have Tulare Encampment and Resolution Project in Tulare Centennial Park, the Safe Encampment Zone. So this is the picture that you see here with the tents. This is where or health education assistant or LBN. They go every Tuesday to provide their services there in collaboration with the other staff from CCT. They also go to Visalia, the local initiative navigation center. And they're going to Porterville as well to the wellness center. So I have a map here, and this is just for a visual representation. So we have Tulare, that is kind of like in the middle of the county. We have Visalia, North County, and then we have Porterville, South County. We have the North and South County mobile units, and this is just to see like the outreach that is being conducted by Tulare County Public Health, that it's strategically in those locations with high concentration of unhoused individuals. Next slide, please. This is the data that we have from last year. So this is July of 2023 to the current data that we have here to see how many people we were able to serve. So as you can see from July, since that's the time that we started to collect the data of the services for provided directly by public health. So to May, we have like around like 630 people that we were able to provide services, and some of the services include like health education, maybe providing some safe sex materials, referral to access medical care, referral to housing case manager, providing maybe COVID-19 tests, provided vaccinations, specifically COVID and flu, oral health education. They also assisted in the point in contact survey. And as mentioned before, they utilize HMIS to make referrals to access medical care. And some of the other services is to arrange transportation to the Visalia Healthcare Center. And I believe this is a summary of all the services that Tulare County or like the efforts that Tulare County Public Health is doing. We are looking to maybe expand those services, working in collaboration with like maybe other partners, for example, Visalia Healthcare Center, to see if there's a way for us to maybe provide like additional services or refer them to services that they're needing. I don't know, Michelle, if you have something else to add.
No, you did great. Thank you, Sarai. And I think this concludes our presentation.
Yes.
Thank you. Here's our contact information.
Thank you. And next up, we have Michelle from San Luis Obispo.
Everybody, thank you for the opportunity to talk with you today. I want to just special shout out to Homebase, to the team. They suggested that I come and talk to you all today about what we've been doing with enhanced care management in San Luis Obispo County Public Health Department, as well as how we've brought our ECM program to life. Apparently it's a little bit unique. So wanted to just throw that out there and just introduce myself, Michelle Shoresman. My pronouns are she, her, and I am the Division Manager of Healthcare Access in SLO County Public Health Department. And we are part of a health agency. So we have in our county, it's not a health and human services agency. Our Department of Social Services is separate, but our health agency consists of behavioral health and public health under one roof. So next slide. So again, I was just asked to really talk about how we became an ECM provider. And it really started back in 2014. We had a group that had been meeting previous to 2014, in order to help our communities really implement the Affordable Care Act as it was rolling out. And once the Affordable Care Act kind of got implemented and was happening in a constructive way, we transitioned the community group that was leading and coordinating on that effort locally into what is now called the SLO County Care Coordination Coalition. And it is a group of health and human services providers that have been convening ever since on an every other month basis, with the goal of really serving the community's hardest to serve people, whether they be homeless or those who are frequently seeking care in many of our hospitals and care provider locations, or with our homeless service providers or behavioral health providers. So we get together every other month to try and set up systems of care to try and really tackle those really hardest to serve people. And as the whole person care program started to roll out across the state, that group sort of became the steering committee for our county's whole person care pilot program. Now in SLO County, we weren't one of the communities that went full force into implementation of whole person care and received Medi-Cal funding for that. Instead, we were one of about 20 counties that implemented whole person care based on a small amount of pilot program funding that the state set aside for programs who hadn't implemented whole person care. And we received a one-time allocation for that funding. It was about $800,000 back in 2022-ish, 2021-ish. And so that money, because it wasn't a significant amount of money, it was kind of just enough to hire a person to really focus on whole person care and CalAIM, as it would soon become known, as it rolled out in our county. So we took those funds and we hired a whole person care program manager and utilized the Care Coordination Coalition to be the steering committee for how those funds would be used and what that person would do. So again, this created a focus for our future whole person care collaboration efforts, and eventually our county's conversion to ECM and CalAIM. And it's always, that funding and that position has always been used to try and help us collectively figure out how to fill gaps in our system of care. And so when all of the details about how CalAIM, ECM, community supports would be rolled out, we utilized that whole person care pilot program manager to kind of lead the charge from the county's standpoint. So we decided, as CalAIM started rolling out and more information about ECM started to become available, there were very few entities who were willing to kind of jump headfirst into ECM in our relatively small county. We have one managed care plan called SenCal Health that spans across Santa Barbara and San Luis Obispo counties. And it was just kind of unclear and messy in our county, as I'm sure it was in many locations, about how ECM was really going to work, how community supports were going to work. And so there were a lot of agencies that SenCal was reaching out to, trying to get them to implement an ECM program. And there, to be honest, wasn't a lot of takers at first. Everybody was just really nervous about it, about billing, about how they would provide these services. And so our county decided, well, we don't have very many takers. So if we can figure out how to fund it, we will jump in with both feet and give it a try. So Next slide. So not have any county general fund in order to hire a care management team for ECM. We thought, well, we'll look for all the different funding sources that are available, and we'll have our whole person care manager lead that effort. So luckily, our whole person care program manager is a pretty prolific grant writer. And so first we applied for some HHIP funds. Those funds were initially used to supplement our very small street medicine program that we had going, where we have a nurse navigator who goes out into the encampments and does a lot of the things that our partners, neighbors in Tulare County were just talking about, provides a lot of health education, gives out a lot of condoms, did a lot of COVID testing at first, has done now some more point and care testing, gives out a lot of Narcan. And also because she's a nurse, she's able to do minimal healthcare out in the field. She does a lot of nursing diagnoses, changes of dressings on wounds, telling people that looks bad, you need to go to the ER for it, or no, that doesn't look so bad, but you should definitely see your primary care. So we used our first round of HHIP to supplement the work that she was doing, buy medical supplies, buy some technology so that she could chart in the field. And then we embarked on an IPP application. Our second IPP, our first IPP application was to fund a behavioral health specialist and a second nurse to supplement our program. And with the existing nurse and the new behavioral health specialist and the second nurse, we started contracting with CenCal Health to be an ECM provider. We then applied for a Path-Cited grant. Our Path-Cited fund is to help us purchase a new electronic health record system and hire a business systems analyst to help us do that and run the RFP process for a new electronic health record system that we can use in public health for our clinic staff as well as our ECM programs, so that we can better communicate between departments or between programs within the public health department. And that business systems analyst is also helping us fund implementation of a community information exchange, which I'll talk about a little bit more in the next slide. Then we obtained a PathTA marketplace fund in order to help us document and write policies and procedures for our newly minted ECM program. And then we applied for a round 2 HHIP grant to fund a community health worker to help in our health outreach efforts and our housing specific efforts in our ECM program. And then finally, we have some county general fund, and part of our pilot project for ECM is to figure out how we can bill for ECM services and see if we can make it sustainable in the long term after our IPP and HHIP round 2 funds are exhausted, because those go through June of 2025. And last but not least, still pending is another Path-Cited application that we won't find out until October to help us further implement our community information exchange, which I'll talk about in just a minute here. So next slide. So this is where my kind of personal role sort of merges with my role at County Public Health. As I mentioned, I'm a division manager for healthcare access, but in 2021, I was appointed to the City Council of the City of San Luis Obispo, and I was elected to that role in 2022. And part of my role on the City Council as a council member for the City of SLO is to serve on a variety of committees that are both countywide and regional. And one of the committees that I'm assigned to is our county's continuum of care, which is known as HSOC in our community. And I was elected to be the chair of HSOC the beginning of this year. So for those of you who don't know, a continuum of care is sort of the entity in a county that helps decide how county, state and county funds will be used to direct homelessness activities. And so being able to both oversee a program that directly serves the homeless and medically at-risk population and sit on a policy-making body that helps direct that work has really given me some opportunities to look for collaborations with our continuum of care and help those find better intersections and better systems to work collaboratively with the county and the cities to do that work. And last but not least, as I mentioned, I'll talk a little bit about community information exchange in our efforts as a care coordination coalition at the county level to help us build systems of care for people that are very difficult to serve. We have been looking over the past couple of years at how to create a community information exchange, which will allow entities who maybe don't have access to an electronic health records or a health information exchange or HMIS, which is used by, as our colleagues from Tulare mentioned, which is used by housing and homelessness entities to track activities around getting people housed. How will the entities that work in these different spheres and in these different silos be able to work together and share data? So that's something that our path-cited funding and our business systems analysts that we've hired with that funding is helping us look towards as a community, creating a community information exchange that all types of organizations can use to communicate with each other. So that was a lot of information in a really short summary, but I'm happy to answer any questions, and I'll take a look at the chat to see if there is other information that people want. Oh, and there's my contact information if you want to reach out directly.
Thank you, Michelle. And next up is Will Nicholas from Los Angeles County.
All right, can you hear me?
Yes.
Excellent. Will Nicholas from Los Angeles County Department of Public Health. First of all, again, thanks to Satika and Alyssa and the folks at Homebase for putting together this great learning series. Very happy to be a part of it. Today, I'll be presenting on how we in LA County have used data from our local health homeless management information system, our HMIS, to improve our COVID-19 surveillance among PEH in LA County, people experiencing homelessness. And while the focus of this is on COVID, I mean, I want to make sure that folks know there's a lot of implications for this for our department for tracking infectious diseases of all types, including STIs, HIV, into the future. But we really had an opportunity during the COVID pandemic to figure out how best to use HMIS data, again, for disease management and surveillance purposes in the homeless population. Next slide, please. So just quick snapshot of what LA County looked like in terms of homelessness right as the pandemic was starting, right? So in the 2020 point in time count, we'd counted over 66,000, which was I think a 12 or 13% increase from the year before. 72% of those were unsheltered, about 28% sheltered. We had over 500 emergency shelters and transitional housing facilities that were housing mainly the sheltered portion of that population. We had recently done some mortality analyses. We continue to do that annually, but we were able to compare mortality in the homeless population versus the LA County population as a whole and found that a threefold gap. So mortality was already much higher in the population. And we knew that unhoused folks had historically high rates of infectious diseases. So bottom line is we had this large vulnerable population that needed a targeted and tailored approach. to COVID-19 mitigation. So next slide, please. So we needed a rapid way of determining the homeless status of our COVID cases. That was really first and foremost. Why? First of all, if we were going to track the pandemic in this subpopulation, do good surveillance, we needed to know who was homeless at the time they were infected. And then also we needed that information to prevent and control outbreaks in places where PEH congregate, including interim housing settings, shelters, and also in street encampments. So the question was, where are we going to get this data on housing status? Next slide, please. So there were limitations to the traditional systems of reporting. I'm sure all of you all, others on the phone, remember these electronic lab reports that you would receive with COVID cases. They didn't contain information on housing or homelessness status. And if any of those cases happen to be homeless, it's unlikely that they would have accurate contact information. We did have some other sources of data that did have housing information on them, but again, they only represented a subset of all the cases reported, so they were useful but not complete. So these included our medical provider, who had a case report form that we created that included a checkbox for housing status, and hospital data also has information on housing status through the ICD-10 codes and through the address data. But again, only a subset of all the cases. So we really needed to know if somebody was homeless at the time of infection, and we also needed, if they were in a shelter, we needed that shelter address so we could do contact tracing and outbreak prevention and management in that shelter setting. So next slide, please. I think this is just to show you an example. This is our COVID-19 provider case report form with the section at the bottom on housing status, just an example. You can go to the next slide. So we did some quick research and kind of identified HMIS as a potential game changer in this area. It was HMIS being the Homeless Management Information System. In this case, it was administered by the Los Angeles Homeless Services Authority, which is what LAHSA stands for. They are the largest COC, Continuum of Care in LA County. It was a time of emergency. LAHSA was extremely supportive and helpful, and helped us get an emergency agreement in place really quickly. We've since updated that. I'll talk a little bit at the end with a more elaborate data use agreement. But the idea was just to get us the data flowing as quickly as possible because we were in an emergency situation. All of the users on our end signed confidentiality agreements and were trained in basic structure of the HMS system, and then we started the work. And so I have 3 bullets here to explain this very technical and complex process of how we did the match. Doesn't quite do it justice, but really quickly. So in May of 2020, LAHSA uploaded basically a first chunk of all their HMIS profiles for all their clients for 1 year back. So we had a 1 year historical data to look back. And then every single day we'd get a new upload of all new HMIS cases, and then the new cumulative file. And so when we had that each day, that data set was joined with our daily, we joined the daily HMS file that I was just telling you about with our daily COVID-19 case database to produce a daily data set of cases with HMIS profiles. So every day we said, okay, this is all of our new cases that have some profile in HMIS. Then we joined that data set to another daily data set that they sent us, which was to the day, all their shelter resident lists. So who was living in which shelter and what were the address of the shelters. And so we matched that to the shelter addresses to get information for contact tracing and outbreak management at shelters. But it's important to note that HMIS data was supplemented with other sources of data on potential homeless cases for a more complete accounting of the PH status of COVID-19 cases, because we knew that HMIS wasn't going to be, wasn't going to get 100%, but it was going to be certainly useful. And so next slide, I think, has some of these other, so these are some of the additional sources of data we use to determine homeless status of the cases. We use rosters of cases and contexts referred to our quarantine and isolation housing. We use the case and contact interviews. You all probably had some kind of case contacting process. We recorded those interviews. We had a script and had a database with interview data that asks about homeless status. We had hospitalization records. We had provider records. We had line lists from outbreak investigations in homeless settings. And then we had direct reports from shelter staff and testing partners. So a lot. And this is what all of the public health nurses and outbreak investigators were looking at, each day to determine who may be homeless and then to do follow-up investigations on that. So in addition to it being really useful for our COVID efforts, having these other sources of data allowed for an evaluation of the added value of HMIS for COVID surveillance. And so what people on the team, I wasn't part of this team, but I'm reporting on this, Alicia Chang, who wasn't able to make it today, leads that team. But they basically published an evaluation looking at, okay, so what was the added value of HMIS, in addition to all these other sources of data, in terms of our ability to do effective surveillance of this particularly vulnerable population. So next slide. These are just the homeless criteria that they use. They went a little beyond the basic HUD criteria, which, this is very modified or brief, but basically if you're sleeping in a place not meant for human habitation, or if you're in some kind of interim housing or emergency shelter setting, those are the main criteria for homelessness according to HUD. Our team also counted couch surfers, which are not officially part of the HUD definition, but they're also very precariously housed, and we wanted to be as inclusive as possible to make sure that we were catching folks who were in need, who had unstable housing. We also included families with children with unstable housing and domestic violence victims. Next slide, please. So this is just some examples of the surveillance reporting that was facilitated by all this data work that I'm talking about. So this is just every week they would report these reports, which would tell you for that week, what are the total new numbers of cases that are verified or presumed to be homeless, and then what's the total cumulative number of cases, and then that curve below shows the cumulative number of cases over time. And then next slide, please. This is just a different report that then shows the cases by week of onset or day of onset. This shows more of like an epi curve over the whole course of the pandemic. And then there's a zoom in on the most recent 12 weeks, so you can see where the trends are headed. Next slide, please. All right, so here's some of the data, and the source of the article is at the bottom, again, led by Padma Jones, this effort. So what they took a 1 year, it wasn't quite a 1 year, it was more than 1 year. So March 30th of 2020 to December, I thought it was 30th, but anyway, so I think it was end of December 2021. So that was the time period of this study for the purpose of the evaluation. And during that time, we identified about 10,586 folks who were experiencing homelessness at the time they were infected. And so this table shows you some of the different data sources that I mentioned, and the take home here is, and this tells you for each of these sources of data, which one was where we first identified the person as being homeless. So HMIS, as you can see, is 26.5, so just over 1 in 4 of our cases were identified through HMIS. The only percent that's bigger than that is the 34.6%, which is this category called PH provider, which is actually a grouping of a bunch of categories. So, probably no one of those would be more than 26%, but that included the line list from all the outbreaks investigations, individual provider reports from our testing partners, and reports from shelter contacts. So all that together was 34%. So anyway, so it was a sizable portion of folks that were identified primarily through and initially through HMIS. Next slide, please. And now this slide shows all the same data sources here on the left-hand side, but what's important here is since we have a large homeless population, the vast majority of which is unsheltered, this data set shows you what percentage of each of the people who are homeless that were identified were sheltered versus unsheltered. And what you can see here is the HMIS and PH provider, which were the two sources that were the highest yield in terms of identification of people who are experiencing homelessness, have actually the lowest percentages in the unsheltered category, which is basically, I mean, part of that is because HMIS, it's a wonderful system, it's really important to have, but naturally it only captures data on people who are interacting with the homeless services system, and so unsheltered folks tend to be underrepresented there. So it's a good thing that we had some of these other sources where we had a higher yield of unsheltered people experiencing homelessness. Next slide, please. Another thing they did was to say, okay, let's look at this whole time period and let's match everybody who with an HMIS, all the COVID cases, and to see who matched, who had an HMIS profile. And so there were 12,589 cases during that time period that had some record in HMIS. And of those, almost half were homeless at the time of infection. And so that was a bit of an issue, right? Because, I mean, by design, HMIS is collecting data not only on people who are currently homeless, but they're also tracking them through their transition into permanent housing, permanent supportive housing, and other kinds of permanent housing, which is a good thing. That's the purpose. But what we learned over time is that for efficiency for doing disease management, we needed to figure out ways to use the HMIS data on program types to narrow that down to the folks who were receiving services through shelters or interim housing, or programs that were literally for people who are currently experiencing homelessness. Next slide, please. I just have one more slide after this. I wanted to show this because this comes from our most recent report on mortality among people experiencing homelessness in LA County. And these MRRs, or mortality rate ratios, are basically the how many times higher was the mortality rate in the homeless population versus the general population. It's kind of like a mortality gap analysis. So overall, people who are experiencing homelessness are 4 times higher mortality rates than the general population. And you can see by cause that some of these causes just really through the roof. So drug overdose was 40 times more higher mortality among the homeless population. Homicide and traffic deaths like 18 times higher, but COVID was only 1.7 times higher. We had, again, as I stated at the beginning, we're really concerned about COVID in this population. Really put out a concerted effort to address and to tailor and target efforts towards that vulnerable population, and we ended up, we can't say that it was a cause and effect relationship, but I like to say there was some relationship between our efforts and the fact that we managed to keep the mortality rate, still higher, but not as high as some of these other causes of death. So, good example of how, public effort can mitigate disease outcomes. And then my last slide. So this is just my summary and conclusion. So, and again, I'm talking COVID-19, but think also future thinking. I mean, COVID, the pandemic's emergency phase is over, but there's a lot of uses for HMIS for other types of infectious disease surveillance. So we found that it was an essential tool for COVID-19 surveillance. HMIS alone was insufficient as a single source for ascertaining pH data. So other sources of data were critical as well, as strong partnerships with medical providers, particularly in relation to unsheltered pH. We learned that use of HMIS program data helped narrow down the profiles to pH who were homeless at the time of infection. So there's ways to use the data in HMIS to help with those efforts. And then in bold here, I just ending by saying that we recently, and this is just brand new, this is hot off the press, in the last couple months, we recently executed an expanded data use agreement with our continuum of care, LASA, for use of HMS data for across any reportable condition in California. It's from the California State of list of reportable conditions. And we have a DUA that we have in place for that. And if folks, want information on that in particular, it's more technical, but we're very excited to now institute some of these processes for all of our infectious disease and vaccine preventable diseases in the future. So thank you very much. Appreciate it. Appreciate the time.
Thank you, Will. And for questions, we did set up questions midway, but just for time's sake, we're going to ask everyone to put their questions in the chat for the for the 4 presenters you just heard. And we're going to start off next with San Francisco. Dara, are you here?
Dara was having some technical challenges. Oh, there you are. Great. Hello.
I did manage to unmute myself. Hello. I've been stuck in a loop of Zoom registration and attempts to join. So I'm joining by phone, and apologies for that, but I'm happy to be on. Are you guys able? I will walk along with the slides by myself if you're able to see the one that says bringing services to shelters and PSH.
Yes.
We do see that. Yes.
Perfect. Should I kick it off?
Yes, please. And just let us know when you're ready to go to the next slide.
Wonderful. So my name is Dara Papo. I'm with the San Francisco Department of Public Health. I oversee a section of the health department, which is called Whole Person Integrated Care, which is a section that has a number of healthcare programs serving people experiencing homelessness. We are going to talk about 2 of them, which is sort of our deepest intersection with the homeless response system. In San Francisco, we have a separate department, the Department of Homelessness and Supportive Housing, which runs the shelters and permanent supportive housing, some street outreach and coordinated entry. And then the health department has some corresponding healthcare services that intersect. So in some ways, we are navigating our relationship with health and the homeless response system through separate departments. I know that in other areas, sometimes these are done under the same umbrella. Another sort of interesting aspect of San Francisco is that we are both a city and a county. So in some ways that helps us work more collectively, and in other ways it causes its own set of complications. So San Francisco has a pretty robust sort of investment over the past couple of years in both shelters and permanent supportive housing. And from the health department side, we've really worked to be able to bring services on site to people that are engaging in those services. I will say that most of these services are not COC funded, so they're not part of the federal funds that our county city receives. These are primarily local investments that are either made using general funds or through some taxes that have been sort of levied on businesses called Proposition C. So if we can go to the next slide, we will talk about our shelter health services. And these services started probably about 10 or 12 years ago when it was identified that the bulk of 911 calls were coming from shelters. And a pilot was created to bring a nurse and a sort of roving medical provider into the shelters to provide healthcare services. And 911 calls from shelters dropped by 50%. And so that was really sort of the launch of our shelter health services. And the goal is that there is a sort of half-time nurse and health worker for 100 clients in the shelter. And so given that there's about 3,000 shelter guests across 20 shelters and navigation centers in San Francisco. Our team in total is about 20%. There is also some mobile behavioral health care services, which are, because the DPH is large here, run out of our behavioral health department, but works really hand in hand with shelter health. Depending on the acuity and size of the shelter, we have shelter health staff on site from 1 to 5 days a week. And again, these are services that are funded through a work order from the Department of Homelessness and Supportive Housing. If we can go to the next slide. So we really look at shelter health services sort of having 3 different components. There is the stabilizing, direct service care, and transitioning. And as far as stabilizing, there is a level of emergency and urgent care that is provided on site, and then the team will work to help triage people to the appropriate level of care, working with sheltered guests on their health goals during their stay. At various points in time, shelter stays have been time limited or non-time limited. Right now, sort of as an outcome of COVID, we have a number of people in shelter that don't have a sort of limit to the amount of stays. So our shelter health team is sometimes helping provide more of that sort of transitional primary care for people that they're working with for an ongoing basis. There's a lot of focus on care coordination, including connecting people to primary care, sometimes to palliative care, for people that are sort of end of life or in need of, programs like medical respite, population health, infectious disease follow-up. We really did appreciate that during COVID, in addition to all of the other infectious diseases that could, quickly spread among people living in a congregate setting. There's been a lot of work that shelter health has done, both as far as identifying infectious diseases as they are emerging, and really working to educate the shelter health staff about best practices for on-site isolation, containment, hand washing best practices when there are norovirus outbreaks and things like that. And they do actually have a small room that they use as a clinic, which is demonstrated in this picture here. If we can go to the next slide that talks about some of the types of care. We do on-site testing for infectious diseases. A lot of individuals in shelters have a number of chronic diseases that have not been well managed previous. A lot of case management, care coordination, wound care is something that we both do on site through shelter health, as well as connecting people to existing resources. A lot of work around medication management and immunizations, as we've been responding to the opioid epidemic, especially with fentanyl. There's been a lot of work with harm reduction and connecting people who are interested in medication for opioid use disorders, including doing telehealth visits to initiate bupe starts or refills. There's also been a lot of education that's been provided to the shelter health staff about overdose prevention, and really just sort of working with the shelter health staff just around the policies that are in place to support people who might be using drugs, such as if somebody has if a shelter has a no drug use policy, really working with them on how do we support somebody that might have had an overdose on site, not have a restriction of services from shelter. If we can go to the next slide, the goal is, as much as possible, working with people who are transitioning out of shelters into permanent supportive housing. or other places, maybe traveling to reconnect with family, to make sure that they're either connected with existing care that can follow them in their next destination, and really working with a number of people whose healthcare needs are too high need to be successfully managed in the shelter. And our nurses do a lot of care coordination to connect people to medical respite, boarding care, residential care, skilled nursing facilities. If we can go to our next slide. We have two healthcare programs that intersect with our permanent supportive housing. The newer one is called FACS, Permanent Housing Advanced Clinical Services, FACS with a PH. San Francisco has a robust investment in permanent supportive housing with over 100 buildings serving over 9,000 tenants, including non-resident family members. That number is somewhere between probably over 10,000. Our ongoing challenges of people experiencing homelessness who are unsheltered is not due to a lack of investment in PSH, but we really have only about 11 buildings that have on-site healthcare services, which really left a gap of over 8,000 tenants that didn't have healthcare services on site. And so using a business tax for homeless services called Proposition C, the FACS program was created. In true collaboration, this is overseen by two different sections of the health department and the Department of Homelessness and Supportive Housing. So we really bring the integrated care into this program. It is a multidisciplinary team of over 20 staff, which includes behavioral health clinicians, nurses, nurse practitioners, and healthcare workers. There is both non-urgent short-term care being provided. The bulk of the work is really focused on supporting the on-site housing staff around consultation, coaching, and training. Some of the initial referrals that came into FACS were, how do I help my client connect with a primary care provider? These are things that we are using coaching and support so that the on-site case manager can then support their other tenants to do likewise. When we find that there are a number of referrals coming in, people with diabetes, people with medication management, we're using that to come do health fairs, do presentation at community meetings, so that there is sort of a limited amount of direct service. Some individuals that would be followed ongoing, and most people having some sort of short-term support, either directly with the tenant and in coordination with their case management staff to provide some short, medium-term stabilization care and linkage to community services. This is we do have an enhanced care management CalAIM component of our FACS team, which is some of the ongoing services that we provide. And if we can go to the next slide, we have, again, funded by the Department of Homelessness and Supportive Housing, 11 PSH sites serving about 1,000 tenants that have an on-site nurse embedded as part of the care team, sort of ranging from, a third to a full-time FTE nurse, somewhere between 1 to 5 days a week, depending on building size and acuity. A lot of their work is really not so much doing direct hands-on nursing, but more the chronic care management and consultation, linkages, care coordination, arranging transportation, coordinating teaching and IHSS, healthcare worker, how to administer insulin, how to set up Mediset, navigating refills. So a lot of the sort of triage work and less of the direct service nursing, but that is a component as well. And so while our goal is always to help people connect with existing services, as one of our medical directors says, appointments are the enemy of people experiencing homelessness. And so given the challenges we've seen of shelter guests and PSH tenants, connecting with our existing more appointment-based care model, we have found that whenever we can bring services on site to provide support for the CBO staff, and some direct stabilization and support, we have both been able to sort of reduce EMS calls and emergency department visits in these populations, as well as having the staff on site that can help do some of the direct navigation for people that are able to connect with our four walls existing clinic. And on the last side, we have my name and contact number in case you have any follow-up questions. I'm sorry I can't see all of your faces, but thank you for letting me talk through this by phone.
Thank you, Dara. And next up, we have Arlie from Madera County.
Good morning still to everybody. My name is Aurelie Cruz. Let me start my camera here. My name is Aurelie Cruz, and we have our mobile health teams at Madera County Department of Public Health. So do you want to go to the next slide? Our mobile health mission statement is to provide comprehensive services to our underserved residents and those with limited access through innovative technology and equitable services. Our commitment to excellence and compassion drives our efforts to ensure residents have access to care. Next slide. Our goals are to provide preventative healthcare services and education to improve overall health outcomes, deliver timely and appropriate care to reduce health disparities, collaborate with partners to ensure the services are integrated. And next slide. So our menu of services. Our two mobile vans are both staffed with 2 medical assistants and 1 health education specialist. We really wanted to kind of provide the education component and the service component. Unfortunately, we do not have a nurse on site. We do have to borrow one periodically depending on the services we want to offer. So if we do vaccinations, then we collaborate with another department within our public health section and are able to kind of elevate those services with the support of a nurse on site. But generally our wellness checks do include blood pressure checks, body mass index, BMI assessment, health service referrals, and immunizations. We do adult preventative vaccines, flu, child school vaccines. So we do MMRs, TBs, COVID vaccines, and our annual flu vaccines. And as for health screenings, we do glucose testing, A1C testing, STD testing, and HIV testing. And aside from our clinical component through our mobile units, we have a enrollment and education component. So we do provide services regarding WIC, diabetes prevention, healthy eating habits, and enrollments to Medi-Cal, other partners who send us information that they would like us to share. And we do naloxone training and distribution as well. So next slide. So community collaboration and engagement. Our units operate 6 days a week. And we are accommodating to Saturday events, periodically Sunday events as well. We just think our population need to have flexible hours. We do events late into the evening as well. Generally, we have a big monthly event right now called our One Stop Shop. And it's really focused on creating linkages to care in the community. So those events typically run from 6 p.m. to 8 p.m. just to accommodate working hours, parents and families, and we have great success with those. So next slide. So best practices focusing on homeless and those that have been displaced. We do have funding that targets populations that are suffering from chronic disease, transportation, lack of housing, and homelessness. So our best practices has really been collaborating with other agencies. So we collaborate locally with our CAPMC organization and their housing coordinator. So they really kind of bring to us the hotspots that we should be setting up at, the hours, services, and locations. Our biggest event that is most successful is really setting up near a river here in Madera. So it's like a riverbed, and that's our biggest hotspot. The coordinators from Camp MC help us with canvassing. So we do canvass about 2 to 3 times before our event, and they go out and support us through their already established relationships with the community. So we share flyers, we let them know the times. Even the morning of, we kind of do a walk through the river with the coordinators just to let them know that we're there and we're going to be setting up and offering services. We kind of implemented too a bit of a case management and incentives. So we do bring out food, snacks, water, and one of the biggest things recently has been a phone charging station. So we set up a phone charging station during their wait. So if we do STD testing or HIV screenings, there is like a 15 to 20-minute wait to get rapid results. And then from there, do confirmatory tests and so forth. So the phone charging station has been greatly utilized. And just the water and food, my staff has like really embedded themselves in creating relationships and building trust. So they bring snacks for their dogs, just kind of we have fans and misters out there for our waiting area. So I think it's really kind of opened the door in offering services and linking people to care. Another big component in this is we do collaborate with the health navigators, and they do the Medi-Cal enrollment. So a lot of people come up already kind of syncing those two things together with the van and Medi-Cal enrollment. So they come up and get request a card if they lost theirs, or request what they're eligible. I think a lot of people don't really know what type of Medi-Cal they have or what services they could get. So it's really like a big Q&A for them to ask questions. The health navigators are a great partner. Like they have driven people to the department because they already have their cards that get shipped to the office, and and that relationship gets built as well. So it's been really great to see that getting developed. And screener questions. So this funding is specifically for those that have been identified to have transportation issues, housing issues, and chronic disease, as well as homeless. So we do have a series of screening questions to filter those patients that are eligible. To receive services through this funding, but as well, we do not turn anybody away. So like in eligibility, I did put some data in here. So 63% of the people we see have chronic disease, 20% have transportation issues, 15% have said to have unstable housing, and 15% are homeless. So, and then number of events by month. So just an average, in the month of March, we do about 20 events. And then in April, we did 30. So since we have two teams, we alternate a Saturday a month, a team will work just to have that extended hours and availability for services. Next slide. Oh, so if anybody has any questions, here's our website, email. You could scan the QR code and it sends you to our request form. So if anybody in the community has an area they would like to be at, for us to be at, or an event, they can go ahead and request our mobile van unit. Thank you, everybody.
Thank you, Aurelie. And next up is, and if you have any questions for the past two presentations, please add them to the chat. And next up is Sacramento.
Lynanne, you're on mute.
Hello, everyone. So happy to be here today with all you great people. I wanted to quickly introduce myself and our team. My name's Lynanne Svensson. I'm Director of Nursing, Sacramento County Public Health. Our first speaker is going to be Kyle. Kyle is a manager in our Sexual Health Promotion Unit, and she oversees our mobile vehicle that goes out for STD, STI, and HIV testing and treatment. And then second up, we have Lisa Hooks. Lisa Hooks is one of our nurse managers here at Sacramento County Public Health, and she's also the director of our maternal, child, and adolescent health programs. So Kyle, you're on.
Thank you, Lynanne. You can go ahead and go to the next slide, please. Okay, great. So I'm going to talk to you a little bit today about our Wellness Without Walls, or W3 program, as we call it. So W3 is a Sacramento County partnership between our divisions of public and primary health, which are both within the Department of Health Services here in Sacramento County. And our program launched in September of 2022, and it's funded with ending the HIV epidemic dollars on our public health side, as well as some braided funding from the primary health side, which includes some HRSA dollars. We provide a variety of services, including basic primary care services, wound care, Narcan distribution, management of some chronic health conditions like diabetes and high blood pressure, as well as rapid HIV, hepatitis C, and syphilis testing, which includes confirmatory blood draws as needed, and extragenital screenings for chlamydia and gonorrhea. The program serves a number of unhoused communities, including large campsites along the American River and under overpasses downtown, as well as some transitional housing sites with tiny homes and FEMA trailers that are managed by the city and the county. And for those, we work very closely with local agencies that oversee those sites, like Community Health Works and First Step Communities. And we coordinate those services and communicate very closely with our patients' case managers to assist with things like medication pickups and follow-up appointments, which has been really helpful for us. This program has really been a collaboration right from the start. We work with lots of county partners, like our immunizations program, who comes out into the field and offers COVID, flu, and Mpox vaccines. And we also work very closely with our MCAH encampment team and community nursing team, which you're going to hear about in just a moment. They assist our patients with getting connected to a variety of services and social supports. We also partner with our UC Davis School of Nursing. They provide clinicians for our W3 program, and they've been an incredible support for our team, both in the field. They've helped to build the capacity of our team quite a bit since the beginning of our program. Then there's the private entities that we've been lucky enough to connect with, like some locally owned pharmacies that are in our area who have really shown a commitment to serving the communities in which they work. They've been willing to deliver prescriptions to us in a variety of different locations. Pucci's and Anderson Brothers pharmacies are two in particular that I just want to give a shout out to. And we've even been lucky enough to work out a deal with our local Noah's Bagels chain so that we've been able to provide bagels and coffee to our patients on most of the days that we go out on our W3 van. Last but not least, we've held a number of donation drives for particular items that we've needed, such as period products, pet food, water and brown bag lunches on occasions, and those have been very effective. And as a result of all of these partnerships and collaborations, we've seen great successes with our patients in managing blood sugar levels, treating syphilis in the field, re-engaging folks in HIV care, and even hearing residents excited to tell us about their new jobs. Next slide, please. Okay, the last thing I wanted to mention before I hand it off to Lisa are just a few observations that we've made since our program started. So from the beginning, it became apparent to us how important it was to serve the pets alongside the people. And I think Aurelie mentioned this as well. It's been a great way to start conversations and build trust with our patients. So we carry dog food and treats and water along to all of our sites. Another observation we've made is the overwhelming need for more resources to treat methamphetamine use disorder. We've seen 63% of our patients report meth use compared to just about 15% who are reporting opioid use. The next observation is that consistent scheduling is really critical. So we see folks routinely and get to know them and their medical needs in order to build trust with them and make progress. We go to the same sites again and again. Even after they get swept, we find that folks tend to return back to those same sites. So we make every attempt to every attempt to locate our patients and then go back to those same sites. And then last but not least, that this work takes a team approach. And we have developed a super strong team that not only includes the folks on the ground, but also the providers back at our brick and mortar clinics, as well as our support staff, our nurses, and our community health workers and volunteers. And with that, I'll hand it off to Lisa.
Thanks, Kyle. As Lenan stated, my name is Lisa Hooks, and I'm the Maternal Child Adolescent Health Director for Sacramento County. And I'm honored to speak to you a little bit about our public health nursing encampment pilot, which went live January 1, 2023. Next slide, please. So for the community nursing program, in particular the encampment pilot, our funding came primarily from the American Rescue Plan Act, the ARPA dollars, and also augmented by the Future of Public Health rollover dollars. So the goal of the community nursing program, we really wanted to bridge the gap in healthcare delivery to Sacramento County residents while considering those very important social determinants of health to achieve positive health outcomes and decrease health disparities. Next slide, please. So the target population for our encampment pilot was, of course, those with unstable housing with one or more health criteria. So we really focused on anyone who was pregnant, anyone who had postpartum delivery complications, any high-risk medical conditions, any developmental delays, and we called them high utilizers of the medical system or anyone having barriers to accessing care, which was essentially anyone we encountered. Next slide, please. So I popped a slide in here just to remind us of the importance of addressing the social determinants of health. So as we all know here, the research shows that the social determinants of health can be more important than healthcare or lifestyle choices in influencing health. So when we built our public health nursing program, we really had to think outside of the box in terms of what the public health nursing intervention would look like, and also what we would consider a success. Next slide, please. So some of the challenges that we encountered, of course, our pilot was limited term. So we did have some difficulty attracting full-time staff, but we were blessed. We were able to use registry staff, and they were highly qualified and just up for the task. They did an amazing job. Another of the challenges that we encountered was the ability to close loop on some of the referrals. As you know, this is a transient population. Times when we make referrals or connect individuals to resources, we may have difficulty locating them when we return for a subsequent encampment day. But despite our challenges, we did have a number of success. Next slide, please.
I think we're missing a slide. Sorry about that. If you could still just discuss those topics, please.
Yes, absolutely. So as it relates to some of the successes that we had with the encampment pilot, as you know, we all have to define widgets when we embark on something new. We must quantify our practice. So we originally set a goal of providing services to 210 individuals, and we were actually able to service over 1,000 individuals with our encampment pilot. We provided over 1,300 referrals to a number of different resources in the community, to include things such as housing, Department of Human Assistance, linking individuals with Medi-Cal, linking folks with oral health specialists, mental health, Social Security, things of that nature. We were able to link several individuals with housing. Some of them were able to obtain permanent housing. We helped individuals obtain identification cards. So we really leaned into those social determinants of health. And then one of the partnerships I'd like to highlight is we worked with our communicable disease investigators to provide rapid syphilis testing in the field. So the communicable disease investigators provided that very important finger stick, and then the public health nurses closed the loop by reading those results so that we could link individuals and start to develop on-the-spot treatment plans for anyone testing positive for syphilis. As you all know, another challenge to those folks living outside is the ability to transportation, if you will. So when we were able to service the individuals in the W3 providers, if the doctors identified a need for a medication, they would actually give those prescriptions to the public health nurses, who would pop over to the pharmacy, fill those prescriptions, and bring that back to the individual so that we could start treatment right there on the spot. We were able to provide wound care and education. We were able to provide supplies. Kyle spoke to this a little bit earlier, but another one of our highlights was to be able to address the concrete needs of those living outside. Our nurse leadership hosted a division-wide food drive, and we were able to take those non-perishable items with us to the encampments. And as was mentioned before, we found that that really opened the door to offering services. I could go on and on about some of our successes, but I think out of respect for time, I will end here. But I would like to thank you for the opportunity to share a small glimpse into the work we've done and will continue to do for the unhoused population in Sacramento County. Thank you.
Thank you. And thank you to all the presenters that spoke today and really gave insight on what of the work that they're doing within their counties and will continue to do. And just for time's sake, I just wanted folks to know that we have one more webinar coming up on June 12th from 9:30 to 11 a.m. That's a Wednesday. And it's going to be on Understanding Cal Ames new enhanced care management and community supports for local health jurisdictions. And if you have any more questions, also, you can email us at healthcare@homebaseccc.org. And the recording will be available on our Homebase website as well as the slides I will send to all participants. Again, thank you everyone for speaking today. And if you have any questions, you will have the contacts of the presenters. So please feel free to reach out to them. Thank you.
Thank you.